Our current paradigm right now with our current technologies and our current therapies are really about entry tear management, as you've heard. The entry tears are the communications or fenestrations that allow pressure to be transmitted to the false lumen, which leads to degeneration of the aorta over time and subsequent complications. And we really, when we're treating these patients, we really have to keep that in mind. And today, in 2018, we're really at the entry tear management phase of our care for these aortic dissections, but I think we'll evolve beyond that with some of the newer technologies. But we really want to cover the entry tear. We want to treat and prevent rupture. We want to reestablish blood flow to the true lumen, as you've heard, and then let these patients remodel. There's an active remodeling process that can take up to 5 years for these aortic dissections to resolve and heal themselves. And you could see that this is a sequential analysis of these patients over a 5-year period of time. Over 2/3 of the patients that, 1/3 of the patients have malperfusion, and 2/3 of those have some degree of malperfusion to a range of different visceral organs, renal organs, and lower extremities. And when we are treating these very complicated and challenging patients, we really have to keep an algorithm and what we call a stepwise approach. We start proximally, work our way down the aorta, and then once we've resolved the initial entry tear, we see whether or not the dynamic obstruction or static obstruction is improved. When we look at the outcomes of patients with malperfusion, they have a significantly higher risk of death and associated comorbidities compared to the uncomplicated patients.